radiation session, and it's my honor to introduce Professor Dr. Ihab Khalil, Professor of Radiation Oncology, NCI Cairo University, and he's going to talk to us about towards a changing radiotherapy practice in breast and gynecology, past, present, and the future. Yes, please.
Thank you very much, Professor Muhammad, for presenting me, and I think that my life is going to be easier in the next coming half an hour, because many thanks to Professor Maya Gigasvili and Professor Marco Cosanzini and Professor Roberto Ricchia and Professor Anna Serrabilia for making the future happen. Protons have been spoken about, IMRT, VMAT. All of these things are going to change the future, whether in breast cancer or in gynecological malignancies. That's why a lot of slides in my presentation will carry the same message like my professors have just said. That's why I'll try to hurry up, but I'll try to corner my talk about whether if there is a need to change in practice in Egypt and in developing countries or no. I think that the first part of the presentation is going to be a little bit interesting, and during the next presenters will present some interesting cases from which we're going to share the opinion and the experience from our distinguished guests about the management of such cases. So, first of all, from the survivors and from the new patients, then we can have the future. We make the future from the data about our survivorships and implementing this for our next coming patients. And that's why we can say that some new patients might be having some better chance than long patients, because technology have been an asset, and most of the deaths of breast cancer have been alleged that radiotherapy is the main cause of death because of the coronary artery diseases and cardiomyopathy. That's why with the innovation of radiation, the new patients might have a better survivorship. So the highest cure rate is the goal, and the fewest complication is the second goal, and survivorship starts initially with a very proper patient and treatment selection. So now I'm going to address a question. Do we need a practice change? Yes? Why?
A lot of technology.
Yes.
A lot of expenses added to such technology. It comes with the price. And the need of the patient to be treated for second line and third line at time of recurrence. Because in the past few lectures we had some speeches about the re-irradiation. So we have a longevity of survival, which mandates finding some new approaches for those patients who are having recurrence at a later time, who receive treatment before. This is one. Second time, how to manipulate for the least invasive techniques that are used right now with all of these breast conservation and so on and so. So it needs also to be co-opted with the radiation. Technology should go with those immunotherapy, the chemotherapy, and that progress comes with the price.
Junior staff, do you have any added comments for Professor Khalid?
Simply to improve the therapeutic ratio.
You can improve the therapeutic ratio. Okay. Thank you for your comments. Then, evidence-based practice change should be number one. And because our distinguished guest said that in very little randomized controlled trials, it's most of the new technology are dosimetric. So, to practice change need 10 to 20 years time to have a practice change. Second thing, improve survival, improve local control, accommodate patients, and this was the notion behind Whelan's in 2003 or something, that we started the hypofractionation because Mexicans have been crossing the Canadian borders, and there was no efficient or no slots for these patients. So when you want to accommodate more patients, you have to think of how to accommodate these patients. And then limited resources is another thing that you can have a practice change. Re-understanding radiobiology, like in the alpha beta ratio of the breast and in the prostate nowadays, we are using more and more hypofractionation, and we are moving in the breast towards the fast forward, giving 5 fractions in 1 week. We are cutting the radiation from 6 weeks to 5 days. So this is again because better understanding of radiobiology. decrease toxicity. This is towards a practice change. Improve quality of life, reduce cost, as Professor Khalid said, and we are a developing country. We don't have the leisure to have a cyber knife and a proton in every government. Trained, experienced personnel is very important and crucial for a practice change. If we don't have these trained team, we cannot have a practice change, because VMAT necessitates a high qualified physicist, a high qualified radiotherapist, and an experienced and trained radiation oncologist. So it's not only a practice change because I have a new machine. It has to be an experienced, trained, and qualified people. And if you have an increasing workload, you have to think how to, as you said, accommodate these patients. So these are the rationale behind the practice change. So in Egypt or in developing countries, I think that we are in need of a practice change. Why? Because this is the only publication we have about our cancer incidence in Egypt. We have about 32 per 100,000 female will be harboring a breast cancer. And for the cervix, it's about 12.6% in 2011. And if we look in the down, we'll be seeing that our patients' population will increase by 188%. So the global burden of cancer are increasing. And we, Egyptian in Egypt, we don't have except 100 or 120 machines. And Dr. Khalid, correct me if I'm wrong, we should be having one LINAC per 250,000.
Yes.
This means that we should be having 400 machines. So we are 25% only from the expected LINACs. And again, this adds a burden, cost burden. So we need to practice change towards a hypofractionation regimen. Africa has few radiotherapy centers, and Egypt, we lie in the range, as I said, 100 to 120. And Africa has got the highest rate of cancer patient deaths in the world, and if we don't adopt proper radiation and efficient radiation, then we'll be losing more and more patients because the global burden of cancer is increasing. So the introduction, adjuvant whole breast radiotherapy reduces the risk of recurrence, improves the survival after breast conservative surgery. We all know this. Radiotherapy to the high axillary and supraclavian membrane results in further reduction in local recurrence. Distal metastasis improvement in survival. In neuropositive breast cancer patient, post-mastectomy radiotherapy to the chest wall and regional node irradiation definitely improves survival. The hypofractionation studies in the breast cancer, most of the patients have been chosen very nicely. Most of them have been N0. Little of them is N1. Here in Egypt and in the developing world, we have a lot of N2 and N3. So the technology is treacherous. If we are going to jump from the conventional fractionation, giving a 6 weeks regimen to a 5 days regimen, and increasing the dose of the supraclavicular fossa, then we are expecting a lot of brachial plexopathy. But even with the recent data of the SBRT, the brachial plexus, the dose of a 6x6 can be less toxic than the conventional fractionation. So in order to jump to hypofractionation, we have to know what is our patient population. So again, practice change should be very much going with our patient cohort. So the radiotherapy evolution from the 60s, this is the timeline, from the standard collimator down to biological and functional imaging. Of course, the advances of the MLC have given us a great asset using IMRT and then a helical fashion of treatment also enabled us to go to a VMAT, and the use of the robotic radiotherapy, which is the cyber knife, is again an asset. So all this are fine, but a very good 3D conformer is needed for 75% of our population. Selected patients might benefit from the high technology, which are in the percentage of a 10 to 20%. Yes, it is very good, but again, on the expense of the cost. So the evolution of radiation have enabled us to dose escalate, and this is definitely have been shown in the IMRT in cancer cervix. If you want to boost the lymph node in the pelvis, or you want to boost a lymph node in the para-aortic. Toxicity reduction, definitely IMRT have shown, and UV mats and SFRT, all of the new technology definitely have decreased of toxicity. The hyperfractionation have been there, and voxelization by planning, changing from a pixel 2D planning to a voxel volume-based planning is very important, and biological planning against an asset, and adapting the patient by their IGRT and the bone MCT is again an advance in radiation, and this will give us a personalized medicine and personalized radiotherapy for each patient by patient. As been shown in the previous session, a very obese patient with a vulval recurrence, so we have to personalize your medicine. And the multimodality management with the surgeon and the chemotherapy and radiation oncology have to push the patient towards a better quality of life. And this is how our margins have been drawn. Most of us here are radiation oncologists, so the margins have been very nicely from a GTV to a CTV, internal margin, especially in gynae, where we have the movement because of the rectal filling and the bladder filling and the uterine movement. So whenever you have a motion, you have to incorporate this and this as an internal margin, and a set of margin makes up your VTV at the end. So what are the 4 pillars of radiotherapy for the junior staff? All of you know, of course. It is the dose, it is the fraction size, it is the elapsed treatment time, and it is the volume. So whenever we want to address a new technology or a new thing in radiation therapy, you can play with one of these 4 pillars. And you should never forget to add the type of radiation and the technique, because we have different radiobiology of protons and of carbon ions, and from low-lead radiation to high-lead radiation, X-ray, gamma rays, brachytherapy. So all of these are different radiation therapy modalities. So these are the 4 pillars of radiation, but never forget that the radiation you're playing with is very important to understand its biology. And the physics of the proton and the carbon ion is very sophisticated. So we cannot practice change unless we are very much trained and experienced. Factors affecting radiation sensitivity have been also discussed by Professor Rikia, that there have been very limited data about the sensitivity of radiation in the patients. The hypoxia, the EGFR, the ER capabilities, the methylation, and the microenvironment and the pH and the normalization. So very little have been addressed in the literature about the radiation sensitivity. And if we can embark on modifying the sensitivity, we can have a better solution rather than using a high technology. So who will vote with a 2D radiotherapy for breast cancer? Nobody is voting for 2D. For 3D? Okay. Whether we're going to give IMRT? Okay, of course, coming from Europe. PDI? Will anybody go with partial breast radiation? Probably more. Ordered fractionation? Okay. So we all are voting towards practice change. Ordered fractionation, we are moving from conventional to ordered, mainly the hypo type. Okay, and the RTOG 1005 is now addressing the accelerated hypo, okay, which is an SIB during condensing or treatment to 3 weeks. And again, the fast forward is condensing to 5 days. And from Europe, of course, we are towards an IMRT, vast experience in IMRT, but we have to play cautiously with IMRT because, yes, there is a lot of constraints, the contralateral breast dose, blah, 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 but the integral dose of the body and the secondary malignancies, this question is going to be answered in 15 to 20 years' time. So the integral dose is an important issue when we are playing with multiple vehicles. The conformal radiation is simply like a chessboard. You can dose paint your treatment, and you can de-intensify your treatment in part of the volume and escalate the dose in another part. So this is the beauty behind conformality and about intensity modulation. The timeline of clinical trials from the breast conservation goes back from the 1990s. So it's almost 28, 30 years time towards a practice change. So you have to have a robust experience and a valid evidence when you want to practice change. Don't forget that we used to play with a good 2D, and we have survivorships. We have a good number of survivorships, but with complications, of course. We used to do matching techniques, heartbeat blocks, the table rotation. The vast experience was in the 2D, more than 20 years. But the complications were the main problem. The cardiac insult, the lung damage, the lymphedema, cosmetic, the skin results in breast conservation, and second cancers. The 2D technique, as you see, a lot of lung and unconformality. The central lung distance should be always kept to 2 to 2.5. This is the best. And this was a very simple simulation, 2D simulation. You should have taken care to keep your central lung distance less than 2.5 and the heart less than 1 centimeter. These were our constraints. Very simple simulation, 10 minutes, patient go to the machine, 5 weeks treatment, and we have survivors. But currently, we're doing CT simulation, we're doing planning, you're doing QA, you're doing CBCT. It's a very, very much workload. So if you want to practice change, you have to have a workload, and you should be prepared for the workload. You have to pay your people well, and you have to change, you have to stay from 8 to 5 working. The workload for a prostate cancer, head and neck IMRT case or chemotherapy is 3 working days, 24 hours. So it is very important. These radiation pneumonitis, if you just in the past, when you moved for more than 3 centimeters, you have a 14% chance of pneumonitis. And the complications is not only radiation. It is a consortium of surgery, hormone therapy, radiation, and chemotherapy. And the lymphedema, if you have dissected level 3, you have more than 15% chance of lymphedema. And these are the congestive heart failures, myocardial infarction, valvular disease, pericardial disease. Time since diagnosis, you can see that most of the curves, after 20 years, they jump. So this is what have we learned from our survivors, that people were dying because of complications of radiation. Cosmetic outcome due to overlap of the internal MAM and the breast in conservative patients, telangiectasia and fibrosis, infraclavicular field and lung disease, telangiectasia in the tangential fields, breast fibrosis. So factors affecting cosmetic outcome, never forget that the breast size and volume and individual radiotherapy sensitivity is very important. And the treatment related is a dose per fraction and homogeneity and the technique. So this all has to be put in consideration. A 20 years follow-up in the Lancet have been shown that for post-breast conservative surgery, for breast radiation, more than surgery and more than 6 months of adjuvant chemotherapy is used, has made us a shift from the 2D down to the 3D and the SRB, the RTOG 1005, from 2014 and still ongoing. So from 1989 to 1996, we have evidence up to 20 years. So in order to practice change, we have to wait for 20 years with the new technologies to see what did the new technology do to our patients. The results, of course, the IBTR was less for the boost, but the fibrosis was higher for the boost. Makes sense. Several groups proposed contouring guidelines. Eastern consensus, delineation of target volumes from Danish, and the vessel-based delineation by the PROCAP, and the RTG consensus. There is a lot of consensus guidelines, but you have to abide to one regimen to have an apple to compare to. Why do you think that accurate delineation of the axillary CTB is critical in the modern breast cancer radiotherapy practice? Because addition of high axillary radiotherapy along with the supraclavian internal MAM to whole breast has shown to improve outcomes in early breast cancer. Axillary front dissection is increasingly omitted in early breast cancer with the use of the sentinel lymph node biopsy. So I think that we'll be back for axillary irradiation. And these are the RTOG contouring guidelines. We are more and more concisely drawing our contours we are trimming the PTV from the, I'm sorry, for the CTV from the pectoralis, 5 millimeters from the skin, because eventually if you want to have a treatment plan with a 95 covering 95, you will not be able if you have a PTV in the skin. No planning system can give you 95% on the skin unless you use a bolus. So even the RTOG is using a PTV eval and they are treating the patients with another PTV. But because of evaluation purposes and because of auditing, you have to trim your PTV from the skin, because simply the planning system will not give you a skin dose. So the conventional IMRT of course will give you a less palpable induration with a very good homogeneous distribution, and as I said, never forget the breast size volume late effects. The larger the breast size, the more effective you have. You can improve those homogeneity by using mixed V, 6 and 15 MV. This is a physical and medical physicist point of view. And this is how we, drawing the high tanges, can be very nicely covered through the tange. And by simple techniques such as deep inspiration breath hold, you can decrease the morbidity to the heart. But it is a little bit subjective unless you have a tracking, then you can go with a deep IVH. These are the constraints, and I said they are institutional based. They're different from the Danish, the Momonis, and Catherine. But you have to follow one thing. The four pillars of the hypofractionation studies are the Canadian and the Royal Marsden and the START A and the START B. The cosmetic outcome was almost hitting 70%, and the hypofractionation, as you can see, because of the low alpha beta ratio, the hypofractionation have been useful, and the hypofractionation have been used from 2002 till 2011. And these four studies, I think, have been going for almost 15 years. Over 15 years, yes. And the group of patients with very small cohort with N1, there was no single patient with N2 or N3. So better patient selection and appropriate patient selection is very important if you are towards a practice change. And this will show you that 75% in the Royal Marsden have been radiated with a boost, on the Canadian no boost, and the START A and START B 60% and 2/3, 50% received a boost. But for the breast appearance, as you see, none of them were of concern, but the 42 gray were better than 39 gray. Tumor boost in the hypofractionation, whether the boost area is a surgical cavity, using an ultrasound, or what electron energy are you using? Are you using the X-ray or no? So without clips, without having a clips in the tumor bed, you'll not be able to delineate your target properly. But the risk of IBTR at the 10 years was only 7.5% in the no boost group, and 61 and the 743 the START B have got a boost. The boost is a problem because you can boost your treatment with an electron beam, which is in the red rectangle, and the tumor is only 3x3, but you put eventually an 8x8. So the boost will add to the, of course, to the cosmetic outcome. So unless you can practice change and you have an IMRT or a BMAT and use an ASA-B, this is going to be an asset. 3D versus IMRT, of course, from the dosimetric point of view, IMRT will give you a very, very good homogeneous dose, and the organs at risk and all constraints will be met. So in order to have an ASA-B, you should, this was a dosimetric analysis, you should go either with a full BMAT or in a hybrid art therapy and IMRT, or the two-field or non-coplanar, and all of them dosimetrically, of course, the full BMAT and the hybrid BMAT will give you a better contribution. A very interesting thing to note is the bone marrow. Also, Professor Orikia addressed this, that the bone marrow in the BMAT, if you are treating a breast case, 40% of the marrow is going to be irrigated. And in the pelvis, if you're using a VMAT, you be having 40% of the bone marrow. If you're using a para-aortic field, then you are jumping to 55% of the bone marrow radiation. So very important to delineate the bone marrow and use a bone marrow sparing technique, which again will not be done without the VMATs or the proton. Let's Quick look about the sequential and the concurrent for the 1005. Of course, 15 fraction concurrent. You're cutting your treatment from 6 weeks to 3 weeks, and you'll be waiting for the results. The fast trial in the UK, of course, the 3 arms trial, cutting down to 5 fractions only over 5 weeks. And again, the primary endpoint was a cosmetic outcome, because we need 5 or 10 years to have the IVTR. So things start like this: a good dosimetric study, then a good cosmetic study, then eventually you go for survivorship. So we shouldn't go for a practice change because of 1 or 2 or 3 dosimetric studies. You have to go for long-term pooled analysis, level 1 evidence of changing the practice. For the hypofractionated regional node degradation for breast cancer, the published data support the feasibility of hypofractionated RNI, again in 14 and 15, but not the 5 fractions. Again, the fast forward trial have been using a physics part of it, when using 5 by 5 and 5 in 5 days, and they're going to use a cohort for testing the doses. The cost matters, of course. Dr. Khalid said this, and we are in a developing country, so the cost matters. So if you have all these things, the nice innovations in radiation, what will you choose? Definitely I would choose the cheapest. And the cheapest, as you can see, the hypofractionated whole breast irradiation plus lumpectomy versus 3D conformal APBI or IMRT APBI. So this is very important in a country like us. The cost matters and the resources matters. So I'll not be going after protons. Yes, we'll be having 1 proton machine, inshallah, but we're not going to radiate all the breast patients with protons. Okay. Again, this is comparative in US dollars. In the NCI Cairo University, this is just a small analysis of more than 500 patients. We have shifted to hypofractionation. More than 75% of our patients are now hypofractionated because of the limited resources, because of the gush of the patients. Again, what about radiation, the oncoplastic surgery? Surgeons are now playing very nicely with breast reconstruction and oncoplastic surgery. What about radiation oncoplastic surgery? It needs a very good collaboration between the surgeon and the radiation oncologist. Oncoplastic breast surgery, the residual tumor foci might be located around the primary tumor, and local recurrence is in the same quiet. The parenchymal rearrangement may lead to alteration of the tumor bed located at some distance. Relocation of the original tumor necessitates that the surgeon should put the clips of the initial tumor bed. In the graph, you can see that the CTB is away from the surgical clips. The surgical clips is of the repositioning of the tissues, but the CTB is somewhere else. So you have to know from your breast surgeon where is your tumor bed. Therefore, TB marking and effective communication should be always very important. Because in the OBS surgery, you are displacing the tissue, you are replacing the tissues, large tissue movement, then clips have to be located. The average volume resected in lumpectomy is 66 centimeter cube versus 180 centimeter cube in the oncoplastic surgery. So wider surgical margin than simple lumpectomy, and you always face a problem with defining the CTB. And the use of the oncoplastic surgery is increasing by time. And that's why without the clips, you'll not be able to identify your CTB. The accelerated partial breast radiation, the mammocyte have been approved in the 2004. Yes, there was some row about the mammocyte, but the target trial failed to have any survival benefit with the mammocyte. This is the mammocyte after loading, or you can use brachytherapy, or you can use the electron beam, like this. And in the target, we have 23 events of recurrence versus 11 events, and the regional recurrence, again, with the target. But the deaths with the external beam have been higher at 5 or 6 years because of the complications. And with the external beam radiotherapy, yes, the cardiac and the stroke were the main cause of death. The future work with the target B, they are testing whether not a tumor boost to be given intraoperatively is superior to where given as a part of post-operative external radiation. These are some selected phase 3 studies for patients at low risk. Again, to practice change, you have to wait for 20 years. Protons in the breast cancer, very nice look in the F and the C. This is post-treatment, but during treatment, you're having a grade 2 lymphoma. Of course, photons versus IMPT. IMPT is very good dosimetrically. Of course, the coverage is very nice by protons. This has been addressed. With the protons, less heart, lung, and contralateral breast dose, definitely. The CyberKnife system provides effective treatment option. This is again a phase 1 clinical trial. And in 2 years, more than 95% of patients and 100 physician rated cosmesis as an excellent. Again, as we said, a good dosimetric, a good cosmetic, and then we have to wait for the IVTR. This is how CyberKnife works, very nicely, more than 200 beams. And it can limit the toxicity, preserve the cosmesis, only 5 fractions, more convenient treatment option than hyperfractionated regimen, but it's very costly. The FDA clears the gamma pod radiotherapy for breast cancer. The gamma pod, again, have been addressed in the ASTRO 2016. It's the same notion like a gamma knife for early breast cancer in the prone position. It's a microsource cobalt and continuously rotates during treatment, and you have collimators up to 25 millimeters. And this is how the patient is put, and then treatment delivery when the patient is put in the gamma pod, you are delivering your radiation like the gamma knife. These are the ongoing RTOG 105 and the imports high, and again, we have to wait for the results.